And last but not least, we welcome Elaine Miller. Elaine is a fellow of the Chartered Society of Physiotherapy, specialising in pelvic floor disorders. Elaine lives in Edinburgh, a city which is taken over every August by the world's biggest arts festival, which is how she landed up exploring the use of humour as a health promotion tool with her stand-up comedy shows about women's health. Elaine is a member of CAN SG and Scott PAG, or PAG. Networks of clinicians with concerns about gender interventions and the wider impacts gender has on women's services. Elaine is going to update us on the research into high levels of testosterone and women's pelvic health and what care women who have used cross-sex hormones are likely to require. And now, ta-da, last but not least, I'd like to introduce to everyone the wonderful, irrepressible, powerful Elaine Miller.
That's an introduction and a half. Thank you. And thank you very much for having me. I am very flattered to be here with such a lineup. I'm faffing with notes because my printer would print them off. And I want to keep to time because I have a habit of rambling on. Pelvic floors and things like that are basically my what I think about most of the time. And then being here with such women that it's just invigorating. It's really exciting to hear what is going on around the world, and it gives you hope. So I'm here to talk about testosterone and what we know it's doing to female bodies. And I thought we'd start off with what is testosterone. So it's a hormone that's produced in gonads, and if you have testicles, you produce lots of it, and if you have ovaries, you produce small amounts of it. And women who produce higher than average amounts of testosterone naturally would land up with a diagnosis of polycystic ovarian syndrome. So it's normal for women to have testosterone. And in fact, there's a big debate going on about whether testosterone should be included in hormone replacement therapy for women that are menopausal or postmenopausal, because at the moment it's only estrogen that's included in that, but your sex organs produce testosterone as well. So why is that not automatically included? And medical misogyny is a phenomenon that is well understood. It has been well researched, well documented. It's been around for 2,000 years. And I think that probably the reason that testosterone use in menopausal women hasn't been properly explored scientifically is because of medical misogyny. In the UK, you can get testosterone prescribed by the NHS if your menopausal symptoms is loss of libido, not for any other reason. So I had a patient saying to me that she had managed to get private testosterone and was talking to her GP about it, and the GP was really interested in her libido. And she said to him, this hormone is making it possible for me to get out of bed and to be able to function, to be able to, have energy to go to her work. So is that not enough? And at the moment, because the science isn't there, because the science hasn't been done, the answer is no, it's not enough. It's only medically relevant if a man needs to have an orgasm in a vagina. Go figure. So there's a big difference between talking about testosterone in HRT with menopausal women and testosterone use amongst females that have got a gender identity issue. They are taking massive amounts of cross-sex hormones. The amount of a dose that they're taking that would have the effect of masculinizing them is unknown. It's a bit of a dark art. There isn't decent evidence to say how much they need to take, and worryingly, there seems to be a culture of adding to your prescribed testosterone dose anyway. So quite a lot of these people self-medicate. That is often related to waiting lists, which are doing terrible harm because so it's doing terrible harm because these people these whether they're male or female with these issues, a significant number of them are distressed. They are unwell, they do have psychiatric symptoms that are left completely unmanaged. They're rejecting their body, and that is always linked with actual emotional distress. And I don't understand why we think that giving somebody large doses of cross-sex hormones is going to improve their emotional distress, any more than I understand why taking a scalpel to their body is going to improve their psychiatric distress. However, I'm sure you all agree with me about that. When a woman takes large doses of cross-sex hormones, the effect of the testosterone, there are physical changes. So her hair growth will increase and her muscle growth will increase. But it also creates a pseudo-menopause because testosterone is a hell of a drug. Like, it's a really powerful hormone, and if you put it in large doses into a female body, it effectively knocks out the function of the ovaries. And female bodies need estrogen. So when you look at things like prevalence of heart disease in women, we're much lower. We present far less often with heart disease than men do, because estrogen has a protective effect of your cardiovascular system. So once we're menopausal, then our risk rockets because we lose the estrogen, because your ovaries pack up. So what happens to these women that knock out the action of their ovaries by taking cross-sex hormones? They become menopausal. Now, it's not a true menopause, because if they stop taking the testosterone, then there's every chance that their ovaries will kick back in and that they will start producing estrogen again. So it's not a proper menopause. The definition of menopause is that you stop menstruating for 12 months and you're no longer producing eggs. So there's a real lack of data about what this population of women are actually doing. Part of that is because in desperation they're self-medicating. One woman that's a detransitioner told me that she had been making testosterone in her house. Like, she learned chemistry in order to produce it completely independently. So goodness knows what she was actually making, but she believed it to be testosterone, and she certainly was masculinized. There's also a worrying lack of effort to attempt to gather data on this population that are taking these drugs. Part of that is because I think that the people that are prescribing the medication simply don't want to know. They display a universal lack of critical thinking. They're genuinely not interested. Somebody presents saying, I am dysphoric and this will make me feel better. And they go, lovely, here you go. There isn't any attempt to make a differential diagnosis to rule out other conditions. This population is disproportionately likely to have conditions like neurodivergence. There is a higher level of psychiatric conditions like, dark triad symptoms. We know that. And also some of the patterns of behaviour that these people display are very similar to the patterns of behaviour seen with people. So they conceal information from the people that they want to get a prescription from. So it's really difficult to get accurate information anyway. When you listen to women who take testosterone talk about how it makes them feel, though, like, I'm really tempted to try it just for a short period of time because it sounds amazing. They describe feeling really self-confident, like they are king of the world within a very short period of taking this stuff. They feel physically really strong, very confident in their own body, which we know that a lot of these people, like, that's part of the reason that they are going down a gender dysphoria route of care, because they feel disconnected from their body. So if taking this hormone suddenly makes you feel like you belong, that must be intoxicating. They also feel very horny, and it's just, it appears to me that their behaviour changes in the way that when I do comedy and you see somebody who's frankly not very funny go into the toilet and come out because they've had some coke, they're suddenly king of the world. it looks like it's a hell of a ride initially. So there is in the literature clear evidence that these people have an initial high. They feel great. That lasts for a year, 18 months, maybe up to 3 years. And then after that, they start to have symptoms that are menopausal and they don't feel so good. Now, one of the interesting things that women have reported that are using high levels of testosterone is the red mist. So they have problems with impulse control. Now, men get this as well because of testosterone, but because they go through a puberty, they start off with an increased rate of testosterone that gradually increases and increases. And then hopefully, they've got good attachment, good parenting, so they learn how to manage the impulsivity and the sexual urges and manage their behaviour. Whereas women who take large amounts of cross-sex hormones have never learned those social skills. So we are seeing, anecdotally, changes of behaviour and offending behaviour that previously was very rare in females. We know that 98% of prison population is male. We know that the majority of the women who are incarcerated are not there because of crimes of violence. If, the argument that you get on Twitter about, some women are violent, they know the names of those women because it's so rare that they stick in people's minds. Whereas if you ask them to name violent men, well, they're 10 a penny. So there's been a case in Scotland that demonstrates this. I'll just try and share my screen. Yesterday, a young person, a 17-year-old, that the BBC reported as a boy, but the Times said was a girl, but trans-identified, pleaded guilty to having a plan to commit a mass shooting in Edinburgh in school. This individual's deeply unwell. And I think that there's a need to look at how the impact of now we don't know, to be fair, we don't know that this young person has been in testosterone, but just like you don't know that somebody that's, wearing a dress and filming themselves twirling around on social media has got a fetishistic reasoning behind that. So I'm going to assume that this young person has been taking high levels of testosterone at 17 and it's impacted her behaviour, and she has got other conditions that have not been managed. The interesting thing about this is that in Scotland, particularly in Edinburgh, they were so captured that teachers get information from the city council and also from the educational institutions that talk about affirmation. So you can have a very dangerous situation where a young person is taking cross-sex hormones and then their psychiatric conditions are dismissed and totally unmanaged. So after this initial high where they feel great, assuming they don't get themselves into trouble because they have unmanaged aggressive behaviour, then the women often complain about menopausal symptoms and they just don't feel so good. I'm sure many of you know that menopause can be difficult to navigate in your 50s. And so if you're in your 20s, these symptoms can become really challenging, not least because you have potentially got 70 years of life ahead of you. So if you're 50 and going through the menopause at the natural time, we're the first generation that would have been expected to work full time during menopause. So there's a number of challenges that are actually, to be fair, a lot of companies, particularly the big institutions, are making quite a big effort to try and retain their talent base. But we have a reduced life expectancy from the age of 50. So if you're 20 and you're having these symptoms, we don't actually know what will happen. High levels of cross-sex hormones are linked with negative effects on many symptoms. So it affects your cardiovascular health, your bone health. These people develop osteoporosis. There's a link with dementia prematurely. And also there is good data shown in males that take cross-sex hormones that there's a link with multiple sclerosis and Parkinson's disease. Now, anecdotally, it seems that there is a higher prevalence in trans men. of that, but there isn't research because they haven't done the research, because women don't matter. Go figure. There's also a burden on women's mental health of the impact of pretending that you have actually transitioned, that you have actually physically changed sex. That seems to play games with these people's mental health comorbidities, which apparently, according to the World Health Organization, having feelings of being transgender is not a mental illness. It's just completely unexplained about why this population is more likely to have neurodivergence, mood disorders, or psychiatric diagnoses, but nobody's thinking about it. There seems to be a universal disregard for critical thinking as soon as somebody says gender. The British Heart Foundation is a big charity that looks after British hearts, and it asks on its website, do trans people have a higher risk of heart attack or stroke? Yes, we know that trans people, whether or not they take hormones, are at higher risk of heart attacks and strokes. Some of this is likely to be due to stigma and social factors which are common for trans people and can affect their cardiovascular health. So that's an accurate statement in that we know that stress can impact on cardiovascular health. But if you apply the Occam's razor approach to this population presenting with cardiac issues, then you would assume that maybe it would be of interest to consider the massive doses of cross-sex hormones that they're taking. So there is data on this. Last February, there was a massive systematic review and meta-analysis published in the literature, and it found that transgender people have a 40% higher risk of coronary heart disease, and coronary heart disease and stroke will shorten your life expectancy. Sharon Davis has spoken extensively about how the swimmers that she competed with when she was doing competitive swimming, the women that were given cross-sex hormones, or in the form of anabolic steroids, it's not technically correct to say that that was testosterone, but they have a similar effect. So those women that were from the Eastern Bloc and given these drugs against their will died prematurely, many of them. So this isn't new information that there's cardiac risk. What I'm worried about is that recording deaths is really difficult if that person has changed their sex marker on their medical records. So that premature death will be recorded as if it's a male person. So we lose the data. We can't measure how many females are dying prematurely or gather data on what killed them or do anything about it. It's really deeply worrying. Now, Reddit is a dark, dark place, but it is somewhere that people claiming to have gender issues gather and share information. And there are multiple posts on there by people who claim to be females and claim to be using high level of cross-sex hormones who report that they're experiencing incontinence. So this really caught my attention because, leaky ladies are my bread and butter. And for an example of medical misogyny, you really can't look for a better example of how these conditions are dismissed medically, easily managed conditions. So this study was done in April last year, and it looked at the prevalence of pelvic floor dysfunctions in trans-identified females. So a pelvic floor dysfunction is where you have a pelvic floor that's either not strong enough to support the organs, so you wet yourself a bit when you laugh or cough or sneeze, or the muscles aren't relaxing enough so that you have difficulty peeing or pooing, or if you indulge in penetrative sex, it's painful and often not very satisfying because orgasms are in part a flickering contraction of your pelvic floor. So if your pelvic floor is working really well, then you have really good quality orgasms. There's not gold standard evidence for that, but you could try a little study experiment of your own. So this study was a good study. It was a very well constructed questionnaire, and it had validated tools to assess incontinence. It looked at sexual dysfunctions and constipation. Now, they only had 6 to 8 participants in the group, so it's a small number, but this is quite difficult to access these people. And also it's done from people who are coming from clinic. So with any luck, they are more compliant with the dosing that they're taking. But the shocking thing from that study was it found that 94% of them, these young people, had a pelvic floor dysfunction. So taking these cross-sex hormones is going to knacker your pelvic floor, 94%. Nearly 50% of them had sexual dysfunctions, and these are young people, like they should be out having fun. 40% of them had bowel issues. And if you struggle with constipation, or if you have bowel incontinence, which affects about 10% of women, then you know how difficult that is to manage. It is one of the most intrusive things that can ruin your quality of life. And nearly 87% of these young people were incontinent of urine. So what does that mean for them? Because women who are leaky at any age, we know that they stop exercising, they stop having sex, they experience anxiety, and they adjust what they do. So they change the way they travel, they don't go on long distance drives, they change what they wear, and they adapt their lifestyle so that they avoid situations where they're likely to leak. There is a difference between the trans-identified females who have got bowel problems compared to women who don't take cross-sex hormones. Often that is linked with birth injury. And so we're going to assume that the trans-identified women who are reporting that they're incontinent, that's not because they've had, an injury to their anal sphincter. But I'm really concerned that we'll see that coming, because some of these people do get pregnant and do manage to, see a pregnancy to term, and their uterus and their vagina are menopausal if they've been using cross-sex hormones, even if they stop with the medication, for the for the benefit of the fetus and to protect the pregnancy. The quality of their tissues has changed, and uteruses need to expand, and vaginas really need to expand in order to deliver an infant. Now, fortunately, the practice seems to be that these women that are delivering their infants, they are automatically going for a caesarean section. But that's assuming that she engages with healthcare and antenatal care and it's all booked and organised. So I'm really concerned that we will see people trying to deliver their baby and sustaining birth injuries that, inflexible tissue. I actually find it really difficult to even think about because it's going to be complex. Now, these papers that I've shown you are both a year old, more or less, and so far there has been no service planning anywhere that I can find to manage and treat these known risks to these populations. It takes an average of 17 years from the publication of a paper to impact on clinical practice, which is a long time, and I suspect that this population just doesn't have that long to wait. So the question that I'm interested in is, why do they have pelvic floor problems? So I'm going to show you a picture of a pelvic floor, not mine, you'll be glad to know. So the pelvic floor muscles are obviously the thing that is filling in the hole at the bottom of your pelvis, and they've got some holes in them to allow your bowel and your vagina and your urethra that attaches onto your bladder to have space for them to exit your body. And the job of your pelvic floor is to squeeze and lift to support the organs that sit on top of that. So that's your rectum, your uterus if you have one, and your vagina and your bladder. So if you look at a side-on version, it's usually described as a muscle hammock because that's what it is. Like, it's there holding everything up. If the pelvic floor wasn't there, your liver would fall out, and that's not great. So it's quite a useful, does a good evolutionary purpose. But this demonstrates to you the importance of having muscle bulk. So if your pelvic floor is strong and bulky, then you've got more strength, so it can do its job more effectively. And we know that with estrogen loss at menopause, you lose muscle bulk, and that affects all of your muscles. So women often discover that opening jam jars is very difficult because they've lost strength. And there's a big push to try and get women that are menopausal to do weightlifting, because heavy weights maintains your muscle, and that reduces the risk of falls, and also you need to open your jars. So that affects your pelvic floor as well. That's why a lot of women have absolutely no pelvic floor symptoms, no leaking, no sexual dysfunctions, no problems until they're menopausal. And menopause is a great leveler when it comes to pelvic floors. It doesn't matter how many babies you did or didn't have, what sort of delivery you had. Once you're over the age of 51, which is the average age of menopause, then we're all the same. We've all got the same risk. So for these young people that are basically debulking their pelvic floor, then they're going to lose some of the support in these organs. And I assume that's what's going on. But we don't know for sure. Now, the good news is that in menopausal women that have got symptoms, we know that pelvic floor exercises work. If it's stress incontinence, if a woman does pelvic floor contractions 3 times a day for 3 months, 94% of them will get dry on their own without any intervention, just with a bit of education. And I don't see any reason to assume that this group of females that are taking cross-sex hormones will be any different. I do wonder about women that are, they've got a small frame, they take testosterone, they go down the gym, they're always filming themselves doing curls, bicep curls. It's quite unusual when you look at the social media content that this population produces, because there's quite a lot of that, which is interesting in itself. You rarely see them filming a workout where they're doing like lats works on gyms. It's often stuff that's done below their shoulder. And I wonder if that's because if you have a double mastectomy, they're losing their shoulder range of movement. And actually they've got shoulder problems as well, but that's not related to testosterone. However, if they bulk up and your muscle mass increases, it can change your posture, and posture has a big impact on how your pelvic floor works. So that might be relevant. So I would assume that what we need to do is just find ways to improve the muscle bulk for these women, and also treat their sexual dysfunctions. Most of them will develop vaginal atrophy because that's what happens when you run out of estrogen. Women will experience itchiness in their vulva. Sex can become really painful. Even some women describe it like having paper cuts in their vulva. And so, looking after their hygiene becomes really, really painful. It's a hobby horse of mine because it's easily treated with localised estrogen. NHS England has just licensed so that you can get yourself over-the-counter estrogen cream to put on your vulva, because it's super safe. Although it's got estrogen in it, it's a very low dose and it's only enough to affect the tissue that it's applied to. There's no systemic effect. So if a woman's got a history of breast cancer or ovarian cancer or endometrial cancer, most of those women can take this safely. And I think that if a woman is prescribed testosterone from a gender clinic, she should also be prescribed estrogen cream for her vulva, but they won't take it. Trans-identified females get very upset when you suggest to them that they need some estrogen, even though we know that female genitals, female reproductive tracts, and pelvic floors need it. So we know that this is doing harm to these female bodies, and we know that there's a need to plan treatment and services and support and help these people. But there's a complete lack of will to even consider this, because in considering it, then you're recognising that some of the effects of transition are unwanted, that these are negative things. And there's a real issue amongst the community themselves, the gender community, where they're discouraged from sharing information that is unwanted effects, because there's a concern that they'll put others off. Like, well, you should. Like, living with these symptoms is really unpleasant. Not having confidence that you can travel on the bus to get to your work without wetting yourself is not nice. So they should be talking about this and they should be finding solutions. And the uncomfortable truth is the solution is probably not having so much testosterone in your body. This appears to be knowledge that is lacking in gender clinicians. So I know a gender clinician in New Zealand, and we had a conversation about this a couple of years ago, and she was completely unaware. She did not know that this was a consequence, because the people that she's prescribing it to, they come back to clinic and they say, yeah, I'm really happy because I've got a beard and I'm bulked up and I believe myself to look more manly, so don't take that stuff away from me. And they don't report the negative effects. And she hadn't done enough due diligence to find out. She was quite happy to prescribe this stuff without the knowledge. So I sent her some information and she said that she would go and speak to her gynecology colleagues and get back to me. And that was 2 years ago. So presumably she's having a problem finding their office, or she was told something that she didn't want to hear. The same is true within physiotherapy. Like, there's gold standard evidence that for these conditions, physio works. Physios are cheap, but there's no workforce planning whatsoever. And it would appear that physiotherapy bodies are, without exception, completely accepting the gender transition as a positive thing, and there are no negative effects. And we just need to wave pom-poms at these people instead of looking at what the evidence base is actually saying. I'm quite cross about this. The further problem with that is that one of the sexual dysfunctions that I find reported anecdotally, but not in the literature. So, there's no, I don't have a reference to show you, but a common symptom is that orgasm triggers uterine cramping. So these people experience pelvic pain that is intense. It can be really like strong discomfort, real pain that can last for 3 days or so after they've had a sexual experience. So obviously that's going to reduce your motivation to have a sexual experience, which impacts on your quality of life and partners if that's where you're sourcing your sexual experiences from. And that seems to be a driver why within 5 years of starting testosterone, a lot of these people are then seeking hysterectomies. Now, people who believe themselves to be male do not want to go onto a gynecology ward, but the surgeons that look after uteruses are gynecologists. And there's some evidence that gynae patients are being housed in urology wards so that we'll buy into the delusion that they're male. They're having their male uterus removed amongst other people that are having surgery that don't have uteruses. Now, I can see the thinking, I can see the logic behind it, because this population of people are pretty non-compliant. So if you can say to them, right, we'll treat you like a man, put you in the urology ward, you won't be around any women because you are a man, there's probably an increased chance that they'll actually attend and have their treatment, because the aim of healthcare is to meet the person where they are and improve things. So I can see the logic. But unless your urology ward is right next door to the gynecology ward, you're using up consultant time. These people are expensive to train and they have skills that would be better served actually dealing with their specialism instead of trailing around a hospital trying to find a different ward. It steals time from the women that they're supposed to be treating. And if there's been an impact assessment done on any place that appears to have this policy, on the impact of that it has on the men and also on the staff who are routinely used to dealing with men. So when you look at blood results and just the sex affects everything. So the basic knowledge that these people are working with, the nurses and medics are working with, is radically different between what they're used to, which is male bodies, and what's been imposed to look after, which is a female person. It just sounds like an accident waiting to happen. So one of the interesting things is that if a woman desists from taking testosterone, her physical changes don't revert. So the hair growth is permanent, the hair growth loss on your head is permanent, the genital changes, so they get an increased size of clitoris, which is not pleasant because it can be very super sensitive and it can extrude from between the labia, so it's not protected and gets irritated with clothing. If you know anybody that complains about this, the only solution that I've heard people find is helpful are period pants, because they're a bit more padded. And unfortunately, it's called clitoromegaly, and it's not going to go away once they stop taking testosterone. You just need to manage it as best as you can. And I asked Will Malone, the medic at SEGM, the American body of clinicians that are concerned about this, which is also, I should have said earlier on, that's what the CanSig and Scott Pag are. It's clinicians here. The websites are very good, lots of information on them. So what Will said was that testosterone bonds to cells and it changes the DNA. So that's why the beard growth is permanent. And obviously that is going to impact on ovaries, because females are born with all of the eggs that you're ever going to have, and potentially the testosterone that you're taking is going to have an impact on that, which has clearly got an ethical issue for if these women go on to have babies. So to finish, I would like us to think about what Andrea Dworkin said, because we should all listen to Andrea Dworkin over everything. And this quote I have at my desk all of the time to sort of, it really struck me when I read it, I don't know, 30 years ago, because feminism is for all women. So sometimes women fall out in feminism, and it doesn't matter, because this is about females and trying to get us equality and trying to get improvement in life for us. And I think that we need to update this thinking to include the women who don't want to be in our class of women, because feminism has to be for trans identified females, even if they call themselves a man or not, because nobody else is going to help them. That's my rather depressing take on it. We've known about this for 2,000 years. Why would they step up now for these people? They get no press, they get no funding, all the attention is on the males, and they are females, so they're part of our gang. Anyway, so thank you very much for listening, and thank you very much for having me. And I think I'm the last speaker, so I assume that Janet will pop in and do something next.
Thank you. That was really wonderful. So I'd like to thank all of our speakers, Jill Ovens, Megan Paul Baker, and Elaine Miller. Thank you so much for being here. It was an absolutely amazing webinar with such varied, incredible expressions of women's feminism around the world, which is just fabulous. So I know everyone is applauding at home in their lounge room or in their friend's spare bedroom like me, and I will turn off the recording and we'll get to question time.